presenter is Dr. Hakimeh Siadat. She's professor at Prosthodontics Department, Dental School at Tehran University of Medical Sciences, fellowship in dental implants, experience in aesthetic dentistry, CAD/CAM, and digital dentistry. A strong education professional with a DDS, MSc focused in dentistry and prosthodontics from Tehran University of Medical Sciences. Dr. Siadat, we are all ears. Thank you for being with us. The stage is yours, please.
Hello, everyone.
Yeah, please begin your very precious.
Hello, everyone. I'm Dr. Siadat. It's my pleasure. I have invited in this webinar as a speaker. And as you know, I want to speak about endocrine. And let me share my
Please speak up. Dr. Siadat, please speak up. Your voice is very low.
Sharing them بس بس. Hello again. I'm Dr. Siadat. It's my pleasure that I have invited in this webinar as a speaker. And as you know, I want to speak about the endocrine. We can discuss about the endocrine and share our experience about it. If is there any question, I would please answer to you in the end of the webinar. Let us start. Okay, when we have the teeth with the remain intact and good structure around the surrounding of the teeth, it's better than you prevent for eliminate of this intact structure. If you were for the post and core restoration for this kind of the teeth, you lost the intact teeth, and it's not good for the teeth, and it's not the conservative restoration. As you see in this teeth, you have very good intact structure of the teeth in the cusp of the buccal, and if you want to go for the fiber post or the casting post, you will lose all of this intact of the structure of the tooth, and it's not preferred and it's not recommended for this kind of the restoration. We have some disadvantages for the routine cemented post and routine cemented fiber post. Casting post is not different between all of them. Placing the post requiring additional operative procedures. You need more appointment for the patient, and then you lost your clinical time. And the preparation to accommodate the post entail removal of the addition to the structure, as I told you in the before slides. The post can complicate or preclude future endodontic retreatment that may be necessary. Then there are some problems with them. And we have the limitation for the using of intra-radicular post. maybe our canals were calcified and we can't go into the canal and engage from them for the making the casting post, and maybe we have the narrow canals, and we're in this situation that we can't making the post for the patient, and maybe we have the fracture instruments into the canal. Then in this situation that we can't using the canal for the making the casting post or fiber post. Then in this situation we recommend to you using the endocrine. The endocrine was first introduced in 1999 with the Bindal and Morman, and it's the only restoration and endodontical treatment fit. It's preservative restoration, and it's more conservative post and core. It's an adhesive single partial restoration, and it's monolithic ceramic restoration. We use in this restoration the monolithic restoration without layering, and this kind of restoration encouraged in the pulp chamber according to the adhesive. The retention is in both sides. There are some indications for this kind of the treatment. When we have the limitation in the occlusal space, especially in the second molar, sometimes we don't have enough space for occlusogingival crown. In this situation, because this kind of the restoration don't need the layering, and it's the monolithic restoration, we can use it. And in molars and premolars with calcified canal, narrow canal, or fracture restoration, a fracture instrument into the canal, you can use this. And molar and premolars with about 1/3 of the crown structure. They can use this kind of restoration in this situation. Our teeth must have about 1/3 of the crown structure, as you see in buccal and or the lingual side, or in the proximal side of teeth. We must have 2 millimeter buccal shelf. In this situation, your restoration can sit on this steps and make very good retention, as you see. Longevity and effectiveness of this treatment plan has proved with the articles, and survivability of this treatment is 99%, and success rate of this restoration is 89.9%, and it's approved very, very high in the molar position. But in the premolar situation, you have to be precaution for this treatment plan, because the premolar is very small teeth, and for getting the aesthetic, especially in the small line, may you reduce the buccal shelf, and in this situation, maybe you lost some of very intact structure of the tooth. Then in this situation, you need go into the canal and engaging the restoration into the canal. I may have some waging in this situation, but we don't have enough article for the premolars. And we have some contraindication in some patients. When our patients have the poor functional habits, it's not recommended for them, because in this situation, maybe the remaining tooth have some fracture, then it's not good for this patient, and poor function must be treated before starting the treatment, this kind of the restoration. And when you can't get the very good isolation. Saliva isolation is not good. You can't use this kind of the restoration because the retention of this kind of restoration is according the banding and the mechanical rotation into the pulp chamber. Both of them are very necessary. Then when you didn't have the saliva isolation, you can't do this. And we need less than 3 meter depth in pulp chamber of the teeth. If you don't have enough space in this situation, the mechanical retention of the restoration will be reduced, and then we can't recommend for this kind of the restoration. And we have a lot of advantages for this restoration. It's a conservative preparation and treatment, and you can save the intact the structure of the teeth, and we don't need the crown lengthening. It's very important. If you check it very carefully, crown lengthening is a very huge surgery for the patient and for structure of the tooth. The patient have to pay time and pay money for this surgery, and the teeth may affect for the reduced bone and tissue. Then crown root ratio may be compromised, and protection of bone will be decreased. Adjustment teeth maybe have some sensitive after this surgery and maybe affected the aesthetic if you are in the smile line. Then the crown lengthening is the crown lengthening can be very bad for the teeth. It's not always good, and in this situation, we don't need the crown lengthening surgery, and we don't need the fold because all of the sitting finish line is on butt joint system without chamfering or beveling. The hygiene of the gingiva and healthy of the gingiva is very good in this restoration because you are far from the gingiva. The finish line of the restoration is far from the gingiva. As you see, you have the buccal, lingual, or both side, or maybe proximal side shelf for setting the restoration, and the finish line is far from the gingiva. Then you have very healthy gingiva in compared to the post and core complete crown. At that situation, your finish line are completely near the soft tissue. This kind of the restoration is very fast, and when you have the digital equipment in your office, you can get them to the patient in one session. If you have the scanning computer and prepping ceramic machine and furnace, you can deliver it to the patient in one appointment. And if you don't have the equipment, it's not problem. You can send the impression to the lab, and using the CAD/CAM technology in the lab, and after 2 sessions, you can deliver the restoration to your patient. But we have some disadvantages with this kind of treatment. We have the risk of debanding when we have the patient with the profunctional habits, or we have occlusal prematurity in the restoration. Maybe we have the debanding of the restoration. And if we can't have a good isolation for the saliva, we can't get enough banding for the restoration, then we have the risk of debanding for the restoration. Another problem is the risk of the fracture of teeth. If you can't follow the thickness of the shoulder in the surrounding of the teeth and decrease this structure less than 2 millimeter, maybe you have the fracture in the structure of the teeth, but you don't have any structure of the restoration, because the thickness of the ceramic restoration is very high, more than for example 2 centimeters or 1.75 centimeters. It's very thick. Then you don't have any fracture in the ceramic restoration, but the risk of the fracture in the remaining structure of the teeth will be happen. And when you don't have enough structure of the crown and only remaining the root, you can't do this kind of restoration. And there is a very important question: which kind of ceramic is used? Which kind of the ceramic you prefer? We have a large variation of the ceramic today, and you can select which of them then you like them. They have very different specialty, colors, and structures, and strength. Then you can select between them. As you see, we have silicate ceramic or oxide ceramic, and from feldspathic ceramic that they have very little flexural strength, up to zirconia oxide ceramic that they are very high flexural strength. We have this kind of range. They are very kind of ceramic, but in this situation, we prefer introduce your lithium disilicate ceramic and hybrid ceramic for this kind of the restoration. This kind of restoration, like feldspathic or Empress cat ceramic, they are beautiful, but they don't have enough fracture strength. And in this situation, the ceramic with the zirconia are very hard, and they have very high flexural strength, but they didn't have enough bonding in the tooth. Then we prefer select from this situation lithium disilicate and hybrid ceramic, because they have both a specialty of this kind of the ceramic. They have aesthetic, and they are beautiful, and they have enough flexural strength. IPSC Max is one of the famous ceramic for this situation. This kind of the restoration, this kind of the ceramic can full contour with the minimum 1 millimeter thickness, as well as thin veneers of minimum 0.4 millimeter can be produced. It has very, very aesthetic, it's lifelike aesthetic, and very good mechanical properties. It has a wide range of translucency, shape, size, and offer for this kind of the restoration. The material produce excellent clinical result and enjoy very high customer satisfaction. As you see, we have different translucency with high, medium, and low. This three kind of the translucency, you can use it for the endocrine. And we have a lot of shade according to the Vita shade. Then you can use it and select it. And we have different position that you can use this kind of the restoration. But today only we speak about endocrine. We have some advantages with this kind of the ceramic. You can use it in CAD/CAM or the ingots in press system in the lab. It's not different. And the flexural strength of this ceramic is about 530 megapascal, and it's suitable for the single or 3 unit situation. It's more possible in conservative dentistry, and it's available for different lab method and furnace, as I told you. The manufacturer block is blue violet, is famous in blue block, and they are introduced you as CAD/CAM block or press-fit ingot. The press-fit ingot is more cheaper than the CAD/CAM block, and the technician use it in the lab. This block is partially crystallized because for preparation in the CAM machine, don't excessive diamond bar wear. And then after preparation in this situation, you can complete the crystallization in the furnace. When the partial crystallization introduced to you as a block, the compressive strain of it is 140 megapascal, and after complete the crystallization, it will be up to 574, and it gets optimum translucency. Another ceramic that's introduced to you and used today very high, it's self-reduce. Self-reduce has a little 10% zirconium oxide into it, and it's very beautiful ceramic, and the flexural strength of this ceramic after glazing in furnace is 370. This ceramic has two kind of the processing with wet fire technique with a stain and glaze, and dry firing technique with only polishing. It's not different between them, only the flexural strength is different, but the crystallization of this kind of ceramic is complete. Then don't need complete the crystallization in furnace, and only for the aesthetic maybe get some stain or glazing, or without furnace only polishing is okay. And the important specialty for this kind of ceramic is marginal integrity for long-term clinical confidence. As you see in this shade, we don't have chipping in the finish line position. If it will be very little, the thickness of the margin will be little decrease. We don't have chipping in comparison to other ceramic. We have some rules for the preparation of the endocrine. Let me know what's them. Okay, in teeth, in all of the teeth is not different between molars and premolars, but because all of articles support the molars position, I will speak today about preparation of the molars. We need 6-degree divergence in the axial wall during the pulp chamber situation. And if they will more divergency, you lost the thickness of the remaining structure, and maybe they go into the fracture during the mastication. We have some orifice, we have some undercut in the orifice of the endodontic canal. Then you must ignore all of them, because if you want to remove all the undercut, you lost all of the thickness of the shoulder of the teeth. Then it's not important. You can ignore all of the internal undercut in the orifice canals. And after that, you can reshape them on the ceramic before the setting. As you see, if you want reduce the undercut, you lost all of the very intact and good teeth. As you see in this picture, when we want lost the undercut in the orifice, we lost the intact teeth. Don't ignore the eliminate surrounding undercut. All of the undercut in the surrounding must be eliminated, and divergency must be done because your ceramic must be have a good sitting. Then if you have the undercut in this situation, your ceramic can't sit. And we need at least 3 millimeters depth in endodontical pulp chamber because you need mechanical and banding, both of them, for the retention of the ceramic and for ensuring for longevity of the restoration. And the minimal 2 millimeters residual tool substance shoulder in surrounded is important. Maybe you don't have this shoulder in the mesial or distal side is not important, but in the buccal and lingual side is better exists this kind of the shoulder. At least 2 millimeters must be done. If it will be decreased, you must eliminate it up to gingival level. Don't forget, omit all of the unsupported enamels around the teeth because if you have the unsupported enamel, the sitting of the restoration not be good, and maybe fracture on this done. Then after that, you have the microleakage from this situation. And all of the line angles must be round, all of them. You don't have any sharp angle. In the ceramic restoration method, it's not different between them in laminate or in endocrine, in lay, on lay, all of them, or full ceramic restoration crowns, full ceramic in this situation. You don't have the very sharp angle. You must have very round line angle. All of them must be round, and it will be good for your situation, for getting a very good impression, and after that setting good restoration on them. And the convex cavity of the bottom is very important. You don't need additional preparation, or you don't need full of them with the glass ionomer or with the composite. This kind of the convex cavity can let you have enough retention for the endocrine. Then don't eliminate this convexity in the pulp chamber, and use it for the increased retention. The clearance of the occlusal must be at least 2 millimeters. Then you need 2 millimeter occlusal reduction for regain the ceramic in this position, and you have the good restoration for the aesthetic and for the strength. It's very important. If your thickness of the teeth is very high, is more than the 2 millimeters, for example, 4.5, 3.5 or 4 millimeters, you can't cut them, and you can prevent. You can have your cast if your cast is complete. For example, up to this situation, you can have your cast without reduce the occlusal, and your restoration can come up to this situation after the cervical groove. It's not important, and you can have your intact cast. It's very good. But when you have only 2 millimeters thickness, you must cut them up to 2 millimeters for clearance of the occlusal, for insurance of the longevity of the restoration. And the preparation must be simple, without very complicated design, a stepping design. It's not acceptable. Without, we don't know, because we don't know furrowing for the this kind of restoration, then all of the preparation is very simple without any finish line. All of them are butt joint. All of them are in the butt joint position without beveling, without chamfering. All of them are in the safe position. Then you don't need any furrow in the buccal or lingual side. The furrow can affect your restoration, and maybe the thickness of restoration will be decreased in this situation, and after that you maybe have chipping during the time or fracture in the restoration. Then you don't need furrow on the preparation. Only in the premolars, maybe you need have this kind of the furrow in the buccal side for aesthetic. If you have this situation, you have eliminate this structure, this remaining tooth structures, because it will be very thin and it's not good for your teeth and your restoration. Then your preparation will be flat in this situation without furrowing, and you need have enough retention from canals, and you need engage your canals into the ceramic. After complete your preparation, you need polish and finish all of the preparation. It's very important. If you know, as you know, we have a lot of there with different hardness. The black one has more hardness, and the red and the yellow one is very fine. Then after complete the preparation, you need check it with the other colors of the there, and after that you can polish them with the rubber, and it's ready for getting the impression. It's very important because you can get a good impression in this situation where without rushing or the place up there on the teeth, and after that you can have a good banding for the bonding for the ceramic restoration. As you see in this article, show the ferrule can affect the restoration, and the situation of them significantly will be bad, and failure can become after getting the ferrule. At a glance, we review the rules of the preparation. As I told you, we don't have any finish line, and all of the preparation must be in 90-degree in the bottom joint, butt joint in the margins, and reduction of the cost will be 2 or 3 meters. It's not more than, and the pulp chamber preparation in the divergency will be 6 degree, and orifical undercut is okay. You don't need eliminate them or eliminate all of this internal undercut, and all of the finish line in the proximal side, all of them are supragingival, and you don't need any crown lengthening. And you don't want go into the canal in the molar position, no engagement of the canal, don't needing, and maybe you have wedging, but sometimes you need go into the canal for the premolars, and we don't have enough articles about them. And it needs more research about it. And all of preparation in the surrounding of the teeth are in shoulder position without chamfering, and enamel wall must be 2 millimeters thickness, and if you don't have enough thickness, you must remove it up to gingival level. And depth of cavity in the pulse chamber must be 3 meters. And less than this is not good. As you see, the endocrine is near to the onlay and inlay restoration for the rules and for the path of the ready. Okay, after complete the preparation, you need recognize the finish line and retraction the gingiva. We have some methods for retraction of the gingiva. One of the famous of them is using the retraction cord. We have a lot of kind retraction cord with some different thickness, but most famous of them that we can use them in more situation are 3-0 or 2-0. These two kind of thickness more using for the patient in most restoration. And the laser, diode laser is the very good device. You can use it for retraction if in the proximal side of the teeth you need some retraction, and if you have this kind of equipment, you can use it. It will be good. And the silicone bar is very famous for retraction in the proximal side. You can use it if you have it. And electrosurgery is another device that you can use it for the retraction of the gingiva. But you must have to know the electrosurgery maybe have some problem for your patient. Sometimes in some patients, after using electrosurgery, maybe we have the recession of the gingiva. Then it's not good for using in aesthetic zone. Maybe we have the recession of the gingiva. Then please use this device very carefully with cautious. Another material that's recommended for the retraction of the gingiva and recognize the finish line is silicone paste. Silicone paste today is very easily and friendly for using. This silicone paste can inject into the gingival sulcus and it retract all of the gingiva very easily. And two of the famous of this silicone paste is Expasil or Astringent. Expasil is related to the Care company and Astringent is related to the 3M company. Both of them are very easily usage, and they have aluminum chloride material, and they can hemostop if you have any hemorrhage in your gingiva. It's very useful and friendly. After retraction the gingiva and recognize your finish line, you need to get your impression. For getting the impression, you have two kind of methods: digital impression or conventional impression. It's not different between them. If you have the device for or equipment for digital impression, you can use it. It's very easily. Today, the digital impression is famous and is very easily for the patient. You can use it. It's very safe, very clean, and it's very fast for the patient. And at the same time, you can have all of the data of the patient into the computer, and you can plan the restoration into the computer. And if you have the equipment of this, it's very good. you can use it. But if you don't have this equipment, it's not problem. You can get the conventional impression with the A-silicone. A-silicone is better than condensation silicone because the stability of them is very high. And you can take your impression with two-stage method. First, you take your putty. After that, after recognizing the finish line, you can taking the wash, and X-light or light concentration is better for getting a good impression. After that, you can send this kind of impression to your lab and using your digital lab for making the restoration. Your technician can scan the impression or the cast with the lab scan and get the information of the patient into the computer. Routinely, the technician scan the cast and the occlusion of the cast, and after that, it's not problem in which method you have your patient information into the lab. After that, in the software, the occlusion will be complete and recognize the finish line on the tooth completely, very carefully. It's very easily, very fast. And after recognize the finish line of the restoration in the tooth, you need insert the axis of the insertion. The path of insertion of the restoration is very important because if you don't select the path of insertion, maybe in delivery session, you can't deliver it and sit it in right position. Then insertion axis is very important. After that, you need some parameters for the restoration. For example, for the thickness of the cement and the thickness of the ceramic in the margins, you have to, or your technician have to determine these parameters. And after that, you can select the crown from the library or catalog of your software and fit the restoration into the tooth, and you can check the contact, occlusal contact, proximal contact. As you see, this blue point are the occlusal contact. You can check it in different position. And after that, it's ready. You can set it into the block. This restoration is ready from the IMAX block. IMAX block set into the CAM device and CXL, the clinical chair side. And after that, it can prepare from the block. It's not different which kind of block you choose or which kind of ceramic according to the specialty you can select of them. We have a range of ceramics for selection, and I introduced to you only 2 of them. As you see in the ceramic preparation machine, at first the machine check the size of the block according your determination, your definition, and after that, when it will be true, it can start for preparation. And the preparation of the crown is very fast according your size of the teeth and according your ceramic material. It's about 7 minutes to 10 minutes. After this time, your restoration will be ready. Okay, I take a breath because I told very fast. And it will be complete. Okay. After 10 minutes, you have your restoration. And but if your ceramic that you choose, if the crystallization of it wasn't complete, you can cut the sprue of it and get it into the furnace for complete the crystallization. And if your ceramic that you choose it don't need the furnace for complete the crystallization, you can polish it and deliver it, or you can stain or glaze, and after that deliver to the patient. It's not different. It's a furnace, some of the furnace for this device. And after that, your restoration is ready. As you see, the stitch have the shoulder in the buccal side and in the lingual side, and in proximal is the level is not high. It's at the gingiva, and you can set the restoration on the position and check the proximal side, the occlusion. And after that, when your patient accepts it, you can deliver it. And you have the range of resin cement for delivery. This kind of restoration, the retention of this kind of restoration is according to the bonding, as I told you before that. And we have the range of the resin cements, the light cure cement or dual cure cement, all of them are in hand. But it's better that with this kind of restoration, you use the dual cure resin cement, because the thickness of the ceramic restoration is very high, and it's better using the dual cure cement. Plus, some of my colleagues using the light cure, and they believe that this ceramic have enough translucency for having the light of the curing, then it's not problem. But I didn't find any articles about it. Then I prefer using the dual cure resin cement for this kind of restoration. Then we can use it kinds of Panavia, F2 or V5 or Relix or multi-link variolink cement or Sirona dense clay, and all of the resin cement in this situation, you can use it. For cementation, you need prepare your ceramic, and after that prepare your teeth before binding. Then at first you need to use hydrofluoric acid gel in the interside of the ceramic. The time of the using this kind of acid is according to your ceramic. If you use Emax ceramic, only 3 seconds is enough, and you don't need more than usage. And after 13 seconds, you can rinse and dry. After that, because we maybe have some more salt after etching with the hydrofluoric acid, it's better, it's recommended using the phosphoric acid for washing this increased salt. But it's according to you. If you want, you can check it or eliminate these steps. If you use it after using, you need rinse and dry. And after that, according to your resin cement, you use the silane or porcelain bond. خب شیر کنیم دوباره. Hello again. Excuse me for interruption. We have some problem with the internet connection. We continue the presentation about the preparation of the tooth. We use the etching into the teeth, and after that we rinse and dry it, and it's ready for the bonding. Using the bonding in all of the teeth, and it's very important. Don't curing the banding because maybe affected the sitting of your restoration. Then after using the banding, you can use your cement, your resin cement into the feet and your ceramic, and after that sitting your restoration. And after sitting your restoration, you need eliminate the excess cement. For eliminate the excess cement, you have several methods. At first, you can use only 5-second curing for the first curing of the cement, and after reduce the excess cement in all surrounding of the teeth in buccal side, lingual side, and proximal side with using the dental floss. You can complete your curing in buccal, occlusal, and lingual side of the teeth. It's the good method for eliminate of excess cement. But if you have some if you want to eliminate the excess cement before curing, it's not problem. You can eliminate it with the microbrush in all of the surrounded of the tooth and clean all of them. And after that, using a dental floss and remove the excess cement into proximal side, and after you can complete the curing. But in this method, you must have purchased for precaution for don't moving the crown in this position. And if your crown have some moving in the position, maybe you lost your bonding. Then I prefer the first method. I curing very little, and after that remove excess cement and complete my curing. As you see, these crowns come from the blocks, and you sit the premolars and molars. In these premolars, as you see, we have the good thickness in the buccal side, and we don't want to change the color of the buccal side of the teeth, and the thickness in the mesial marginal ridge, distal and buccal, it will be good. Then we only plan the endocrine in the space of the pulp chamber and the distal side. It's not problem, and you don't want to follow the preparation method that I told you before that. I told you when you have enough thickness of the tooth remaining, you can have them without reduce the occlusal clearance. And in this situation, we have two premolars next together in the distal of the first and mesial of the second premolars, and all of them stay in this situation, and the marginal ridge in distal of the second and mesial of the first are have the good thickness, and they are in the same level without cutting in the occlusal. And only we prepare the restoration in the remain access point. Then In this situation, the crown is very, very partially, and the partial of the crown, you can see it in the buccal side, and the color matching is very important. If you can't get the color match in the buccal side, maybe your patient don't accept it. Then your matching of the color and selecting the ceramic is very important. As you see, the finish line ready in the computer and the restoration setting. And after that, you can see the result of the delivery of restoration in the position without checking, without understanding where is the line of the cementation. It's very important when you use the very, very partial restoration in this situation. And in this position, your restoration sitting, and you check the proximal side and the occlusal. And after that, when your patient accepts it and don't have any problem with them, you can cement it with a resin cement, as I told you. And in this situation again, you can ready. Then if you have the complete chairside CAD/CAM technology in your office, you can deliver the restoration in one visit dentistry and very, very fast according choosing your ceramic. In IMAX, you have more time, maybe 1.5, and with the other ceramic, then the crystallization of them is complete. Only in 1 hour you can deliver your restoration. It will be very fast, very easily for the patient, and your patient will be happy with them. And you must check the occlusion, as I told you. If you have the premature contact, maybe you have the banding in the restoration, then please be careful on the premature contact. And we finished our presentation. You can follow me in the social media, and if you have any question from this lecture or anything else, I can answer you. Thank you for your attention.
Thanks a lot, Dr. Sirat. It was very informative, very valuable. And now let's go for the questions. The first question is, how would you bring the chance? First question, do we have Iranian-made materials such as ceramics? Second, how did digital dentistry facilitate your work? Any disadvantages?
Is there any advantages for the digital devices?
Disadvantages.
Disadvantages, yeah.
They're asking, do we have Iranian-made materials such as ceramics?
I don't think so. We don't have any Iranian ceramic. I don't have enough information about it, but I never see that for Iranian ceramic. But maybe we have, but I never see them. We have some disadvantages for the digital equipment. The bigger than one is the price of them for ready and by all of them is very high, and the management and maintenance of them is very expensive for the clinician, and you have pay more for ready all of them. But I think today you have to go to this method because dentistry is different with this method. And if you don't have the equipment in your office, it's not problem. You can use it in according to equipment of your lab. And it's very important you move toward to this technology because today's the technology in the dentistry is very high. And if we don't start using technology in our office, we were lost all of them, all of new information, new material, then I recommend please go and start with them, but the price of them is very high. But for the patient, because the patient don't pay any money for the crown lengthening and don't pay time, is better. And in average for the patient, payment is less than when the patient wants have the crown lengthening and have the post and core crown. In this situation, the patient have to pay more. But when patient gets the ceramic restoration very soon in 1 or 2 visit session, it will be better for them and pay less than when they have two kind of the procedure.
I think another this kind of restorations are more conservative, and if it is possible to use them, it is better to use them than complete crown or post-core crown. If there is indication for using this kind of restoration, it is better to use it because of the retaining or keeping more to the structure. And the other one is said using laser to retract the gingiva.
ببین من داشتم حرف می‌زدم دوباره بگو.
Using laser to retract the gingiva for anterior teeth. Will it be accepted aesthetically?
For the laser, yeah?
Yeah. Is it acceptable for anterior teeth? It is a question.
Yeah, using the laser devices for the retraction of the gingiva in the anterior teeth is acceptable. With the laser diode, we don't have the recession the gingiva, but only with the electrosurgery devices we saw some retraction. It's not in all of the cases. In some of them we have a little recession, but after lasering I don't have any articles about the recession. Then I think it's can very good in the anterior side. As you know, the diode laser can use for the reduced pigmentation of the gingiva, especially in the anterior side. Then is useful. It can useful in the anterior side as it's not disadvantage on using in the anterior side.
I hope the question was answered. Another question is, in post and core, we are more sensitive to canal obturation quality. In endocrines, do we apply the same strict requirements when selecting a tooth for endocrine? In post and core, we are more sensitive to canal obturation quality. In endocrine, do we apply the same strict requirements when selecting a tooth for endocrines?
Sensitive.
Yes, I think.
For the من اینو هی میکشم و سیستم میکنم.
The quality of the root quality good. We can't put a restoration, especially indirect cemented restoration, on a tooth with that doesn't have a good root canal therapy. But we don't go inside the canals. And now, please, you explain it.
Yeah. During this treatment plan, you use the ceramic restoration in the endodontic treatment seats. Then your endodontic treatment will be good, will be done good. And it's correct that you don't engage into the canal of the teeth, but your treatment plan in endodontic treatment plan will be good, must be good. If your treatment plan don't work good and maybe need another retreatment, and it's not good for you and for your patient, then when you want come to this kind of the restoration, you must sure for the good treatment plan in the endodontics and consult with your endodontics. And if it sure you the endodontic treatment, it will be good, you can start it, your treatment plan. But if any problem came after delivery, the restoration, if patient have some problem or some pain in their teeth, you need forward your patient to the retrograde surgery and consult with your endodontist. But you must ensure from the quality of the endodontic treatment.
So much. The other question is, what is your opinion for laser to increase the alveolar bone in surgery with bone surgery with lasers?
If you want have a bone surgery with the laser, you can't use diode laser. With diode laser, you only have surgery in the soft tissue. And in this situation, you have changed your device and you need another kind of laser, because our presentation is not about the kinds of laser. I don't speak about this, but you need another devices.
And the other question is, why do we need to retract gingiva in endocrines? They are far from gingival margin.
Because in some situation, your finish line is near the gingiva, at the gingiva, like the proximal side, in mesial or distal, or both of them, or maybe in the lingual side, the gingiva is near to the teeth. Then you need to retract the gingiva because you want to recognize your finish line of the teeth with the camera, or you have it in a good impression. Then you need protection, protect the gingiva you need to retract the gingiva in this situation when your finish line is near the gingiva.
Thank you so much. The other question is, in premolars that we engage the canals, is the minimum 1/3 crown structure remaining rule no longer necessary?
When in premolars restoration and the crown, you want to engage into the canals, you only went to about 3 or 4 millimeters into the canal, because all of the devices, scanning devices, only can scan in this situation, except in the situation that you use the scan post for scanning the length of all of the post space. But when you don't use the post scan, the scanner can scan only 3 or 4 millimeters into the canals. Then for this situation, only 3 or 4 millimeters into the canal can be useful and is completely done.
Thank you so much. It seems that there is no more questions. So we are so grateful, Dr. Siadat, for your very nice lecture, and we hope everybody has enjoyed it. Thank you, everybody. See you a little bit later.
Thank you very much, and I enjoy.
Hello again, everybody. Our last program is Dr. Nokar's presentation of his work at office for making CAD/CAM-made endocrines. Dr. Nokar was the former dean of the department, head of our department, Prosthodontics department. Now, the stage is yours, Dr. Nokar. Thank you for coming.
In the name of God, hello everybody. It's my pleasure to be here with you today. In this presentation, I would like to show you how to design an endocrine using CAD/CAM technology. I go over here to select software icon. Where's my video? Okay. Where's full screen? Oh, yeah. Okay. Okay. Yeah. I go over here to select software icon. We are running version 4.4, as you can see here. Okay. Okay. The necessity is to add a new patient. I'm gonna type the patient last name and first name in the name tab. And you can go through and put in the date of birth and the patient ID if you want. You also can put in the dentist name. In the next step, we are gonna add the case, choosing inlay as the endocrine, selecting the tooth that we are going to be working on, maxillary right face premolar. In the next step, we're going to add the case, choosing inlay as endocrine, selecting the tooth what we are going to be working on, maxillary right first molar, selecting, and then selecting our milling machine. We start scanning from occlusal view of the selected tooth. Slowly move the CEREC Omnicam in the occlusal direction from distal to mesial. Rotate the CEREC Omnicam between 45 degree to 90 degree toward the buccal or lingual. The camera does not rest on the teeth or the gum. So let's scan the lower jaw. After finishing the scanning the upper jaw, the teeth of the scanner move from distal to mesial and rotate to palatal and buccal area. After completion of scanning of upper jaw, we go to lower folder here and starting scanning of lower jaw. We're working, we're working at number 3, so I need to scan basically this little segment of the jaw. We don't need to scan the whole thing. I just need to opposite it and to make sure I have clear image of the buccal. The Omni can scan the occlusal surface and then buccal surface and lingual surface. Rotate the tip of the scanner about 45 to 90 degrees. We are going to completion the lower jaw scan. After finishing the scanning of lower jaw, we start the buccal scan. So now going ahead and scan the bite. The buccal scan tells to computer how two teeth are oriented next to each other or opposite each other, making sure the patient is biting correctly with both sides together at the same time. And so you have to guide them a little bit. After the scanner of bite is completed, software is going. Software is going to calculate the record data in order to produce 3D models. It takes about 1 minute for produce 3D models. Next, we are going on the model tab. At this point, we can edit these models. I'm going to use to cut tool, yes. Choose the cut tool, and let's just say we want to trim off some this extra data. Starting cut with double click, then continue with single click to determine the extra data outline. And the cut with double click. Now we choose the lower jaw and starting cutting with double click at here, and continue with single click and end with double click again. After editing the upper jaw and lower jaw, we are going to the next step. The next step, set The next step is the buccal bite registration tab. In this step, we evaluate the occlusion. If it's not correct, we should go back and scan the buccal bite again. After evaluation of the occlusions, we're going to the next step, set model axis. This step is the model positioning step. We have got anterior premolar and molar teeth region, dragging model on the U-shape area, adjusting midline, paralleling incisal and occlusal plan with the horizontal plan, and go to next step, editing the jaw line. You have to position the dots in order to shape the arch form correctly, and you have to put the blue silicone on the selected tooth here, and go to the next step, trim the selected tooth. After it, draw margin. Margin finding actually very simple. I can either click to manual or auto mode and edit it later. I select manual mode, okay, then I just gonna start drawing, and you can see that the blue line follows the margin pretty well. So we are going ahead to the next step. The insertion axis is aligned as vertically as possible to the occlusal surface. The next step is design phase. The next step is checking parameter. A spacer parameter is checking parameters. A spacer parameter is used to increase or decrease space for adhesive margin. Adhesive gap parameter is used to adjust width of gaps on the preparation margin. Setting occlusal milling offset parameter after that, and then setting occlusal strength, proximal strength contact, also contact of occlusal strength, dynamic contact strength, and marginal ramp angle. After that, we are ready to go to the next step. The next step is morphology design tab. Automatically, the software is going to process restoration. Next step is positioning. I'm gonna start with a position and a rotate tool. Here, position and rotate tool. We can rotate the proposed restoration clockwise or counterclockwise. Or toward the back corner, and then I select the scale. With this tab, we can change the contour of the buccal, add the contour of the buccal, and add the contour of palatal, or if needed, again, rotate the restoration. Choose the scale and adjust the contact, proximal contact, and check the occlusion by turn on the opposite jaw. Also, we can check contact and go to the next step, editing restoration. This is designing of the final restoration, and we have three important tools which can be used to add up, remove, and smoothing the surface. Now, I'm going to choose a smooth tab and drag the tab on the palatal surface. We can change the size of tools, also strength, smoothing the buccal and proximal. Buccal and proximal. Also, you choose add tab and change the size and add here that is 10. Yeah. We are smoothing the next step is adjust meal position. We can change the position of the designed restoration in the block by rotate the block, self-radu block, until the screw lie in the correct position or proper position. After that, we go to the start milling, and as you can see, milling machine is measuring the block size. MCXL milling machine is a 4-axis device. On the screen, you can see the approximate time need for milling, about 11 minutes. Starting mill, the restoration at a rate of 20 micron slices, which is impressive. You can see the medium grit diamond burr grinding self-radu block. Okay. Okay, now that we are done, next step is staining of the restoration. We can use brown color stain on the proximal surface and in bottom of occlusal pit and fissure. We can add blue stain to tip of cusps or incisal edge to mimic enamel and translucency. There are 4 basic stain color. that is most used. Again, use brown stain in the depths of the fissure and pit. The brown stain adding chroma, increase chroma. We can use brown stain in the proximal surface for mimic color discoloration, stain discoloration in the proximal surface and in the cervical of the buccal. We can use the white stain for produce the white spot. After coloring is completed, we are going to place the restoration into furnace. The temperature rises up to about 800 to 850 degrees depending on the glass ceramic material. On the screen you can see the approximate time needed for glazing is about 10 minutes. The next step is trying in the restoration and cementation. We use dual Q7 for cementation, treating fitting surface of Ultra-Do, applying Silan on the surface, treating selected tooth, applying bonding agent, mixing dual Q resin and cementing restoration. This is final result. And thank you for your attention. I'm ready for any answer.
Thank you, Dr. Nokar.
Yes. I don't have.
And now we have some questions from the listeners. Also, they have thanked you. What's the name of program that you were using?
This is Premium Software 4.4 of Silicone Company.
Yeah. Thank you. The other question is, for this type of overlaying, dentist should work by herself or himself, or dental laboratory will produce it?
We can make this restoration by chairside device. Also, we can take impression and send to laboratory for making in usual manner, such as making impression and produce the cast, and go to the digital manner by scanning the cast in the desktop scanner.
Yeah.
Another method is that we use the press ceramic and use the lossless technique. Okay?
Yeah, completely correct. And I think they are asking the name of program to be written. Can you write it on a paper, please, Dr. Nokar? Can you write it on the paper? You said that it was Retract.
Yeah. Yeah.
So everybody, I hope that you have enjoyed our program. This was the last program that we presented to you. Another question is, Doctor, would you please share your video with us separately, not in this platform? For example, somebody sends your video in our WhatsApp group. Perhaps Dr. Nokal can share it on Instagram or on Navid or something somewhere else.
Please.
They are asking you to share it with WhatsApp or Instagram or Navid or something else.
Yeah, I share it in the Instagram, in the
Your page.
Yes, in my page, yes.
Would you please write your page in the address of your page at the chat box? Everybody is interested to have this movie, so please write it.
Yeah.
Yeah. Is there any other question, dear audiences? Yes, sir. The name of the
that I'm writing this. Yeah. Please wait. I'm writing.
And they are asking, can they have your email, please, Dr. Nokar?
Email, yes.
Is there any other question? So I hope all of you have enjoyed our program today, and the program that was presented to you by Department of Prosthodontics. My colleagues were Dr. Mahboli, Dr. Siadat, and Dr. Nokar. All of them did great, and I am so grateful. So if there is no more questions, I say goodbye to all of you. Have a good day, everybody. Dr. Nokar, they are thanking you.
No, thank you very much.
Yeah, they're saying thank you. And they say